participant count's gone up, so I think that folks are joining or rejoining us. I just want to welcome everybody back to PXP. This is our second session of day 3. And this session is Including All Voices, Examples and Advice for Doing Better when Working with Communities Historically Excluded from Health Research. Thanks so much for joining us. I'm Joletta Belton, for those of us who haven't seen me yet. I'm a member of the steering committee and will be moderating this session, where we'll explore how to make patient and public involvement in research more ethical, just, inclusive, and representative. Please engage with each other in the chat and put any questions you may have in the Q&A box so that I'm sure to see them as moderator of the session. I'll be monitoring the chat too, but I'll definitely see your questions if they're in that Q&A box. And I'll get to as many of them as possible during the discussion session. Our speakers today are Sandra Jayacodi, Alma McCormick, Cheryl Davies, and Devan, and Cheryl and Hem will be co-presenting together. Each presentation will be about 12 minutes long, and then we're going to all come together at the end for a discussion. I encourage you to read their bios on the PXP website. There should be a link in the chat, and I'll let each of them introduce themselves in their presentation as they share their experiences, insights, and stories with us. And we are going to kick off this session with Sandra. So thanks so much for kicking us off, and over to you.
Hello, everyone, and welcome. Thank you to the International Steering Committee of Patient Partners for inviting me to participate in this session on Including All Voices, Examples and Advice for Doing Better when Working with Communities Historically Excluded from Health Research. My name is Sandra Jayacodi, and I live in the United Kingdom. I have lived experience of both mental and physical health conditions. I'm also a carer for my aging parents who've been diagnosed with cancer, cardiovascular illnesses, and diabetes. As for my profession, I worked as a lawyer before, but due to poor health, I had to leave my profession and was unemployed for over 7 years. I now wear many hats. I'm a patient advocate, a peer researcher, a patient and public involvement lead, or as some of you refer to it as patient engagement in research. I'm also a quality improvement fellow and a patient and public involvement trainer and lived experience coach and mentor. For this session, I'll be wearing my patient and public involvement hat in research, which basically means using my lived experience and work alongside healthcare researchers to help deliver outcomes that are relevant to people living with certain conditions. It means that research is carried out with and or by people with lived experience rather than being on, about, or for them. So when I was preparing for this session, I asked myself, do researchers purposefully set out to exclude certain communities? Some may use the term marginalized communities, hard to reach communities, or people from different ethnicities in research. I think the more appropriate way for me would be to addressing this issue would be, why were they not included in research? Before that, we need to understand why we need to include these communities in research. It may sound that I'm teaching some of you, many of you already know, but let me, for the purpose of the majority, just give you an example. Black, Asian, and minority ethnic groups are more likely to suffer from poorer health outcomes and health and social care inequalities in general. However, they are much less likely to be represented in health and social care research studies. This makes obtaining good quality research information from and with these groups becomes even more important. Take, for example, if a research is about type 2 diabetes and you know there's a higher prevalence of type 2 diabetes amongst Black and Asian community, wouldn't you want your participants to be reflective of that community too? Unfortunately, recruitment of participants from these communities has been historically a challenging one and still is. This could not be more so evident from the COVID vaccine trial. There was significantly lower number of participants for the COVID vaccine trial from the ethnic minority groups. A recent study published in 2017 in the British Medical Journal concluded that there is a growing awareness of the barriers and facilitators to recruitment of, in this case, South Asian participants to health research studies. Knowledge of effective recruitment strategies and implementation during the grant funding stages may reduce the risk of poor recruitment and representation of South Asians for this study. In 2018, a toolkit was developed to increase participation of Black, Asian, and minority ethnic groups in health and social care research in the UK. So despite the fact that the internet is inundated with information of barriers, good practices, and toolkits to address these problems, yet in reality, the problem still continues to exist. Recently, I came across a researcher who is yet to recruit a single person from a particular ethnic group, despite all the information that is available out there about good practices, and including a toolkit on how to recruit participants from different ethnic minority groups. So where does the problem lie? Is there anything else that can be done? For me, one of the issues that I thought about was, could it be a trust issue? I asked myself, how about investing time and resources to building trust and relationship with communities? Notice I did not just say building trust and community relationship. I said investing time and resources to build the trust and relationship, as the former cannot happen without the investments. Many organizations would say, are we going to build trust and relationship? But then when it comes out to actually doing it, they do not have the fundings to go out to do that. So organizations carrying out research has to be seen in that community, understanding their cultural background, their needs, priorities, and their fears, and their reluctance to participate in research trials. Invest recruiting people from the particular community to be part of your research team, who understands their culture and champions your cause, who is also able to advise you on how to recruit, the recruitment process, help you with the public-facing materials, and even analysis and dissemination of the research trial to that particular ethnic group. Many years ago, if someone has asked me to take part in a clinical trial, I would have said no immediately. I wouldn't even have to think about it. That was because of my lack of knowledge and understanding. But because of my knowledge and understanding of research now, I stand in a better position to at least say I will consider, and being given the opportunity to ask the questions and giving materials for me to make informed decision. Another factor that may be influencing poor participants from certain communities could be the lack of researchers from that particular community. I have been involved in a study where we also needed people from Black and Asian community to set out the priorities for a research topic. All those who responded to that survey were white, and we were struggling to recruit from the Black and Asian community. So we decided to resort to a one-to-one approach and went out to meet the Asian and Black population in their own communities. I went out with the survey forms, and I was very happy because I had a Somalian interpreter with me. So went out to the Somalian communities during one of their meetings with an interpreter. But the leader of the community looked at me, surprised, and asked me, don't you have any people from the Black community in your team who could have come and presented this research? He said that would make his members of the community feel much more comfortable if it was one of them. And it was at this point that I realized that 99% of the researchers I have worked with were all white. This daunted me. How much are the public aware of this? Should we be concerned about it? Why might Black individuals of all groups be underrepresented in leadership roles as well as when engaging in research. Again, in a study in 2020, a research study highlighted that the significance of co-working and co-producing with the community partners and knowing and having experience of the various languages and cultures of the community. The fact that these researchers came from some of the communities they were working with helped them to be aware of how they were seen and positioned by these people from seldom heard communities. This familiarity also enabled them to sense who they were hearing from and whose experiences they may not be hearing from. So it is also important not to always ask communities to come to the researcher's base and to describe things in academic terms. That is not collaboration, but to go out into the community and meet them and understand them. So here are some examples of how we can ensure we include the voices of these communities who have been historically excluded from research. We need change at organizational level. We need to embed the principles of equality, diversity, and inclusion in research from the outset. We need to highlight when recruiting researchers the opportunity for diversity, to include people from these ethnic minority communities. Identifying, training, development, and mentoring needs for staff who may want to be involved in research. It could be a career progression. Have fundings that allows for pre-work and relationship building with communities. Funders for research have to proactively encourage and support inclusive research, even giving feedback to unsuccessful applicants, or even set it up as a criteria for genuinely inclusive research. Make it expectation. A friend of mine would say, not a nice one to have. Recruit and train peer researchers from that community. You need to involve patients and public from those communities in determining the research questions as well. Provide opportunities for everyone to offer fresh perspective on research. Sometimes I would say, come with a clean slate of paper. Where members of the public share their knowledge and lived experiences, remunerate their contributions and facilitate this by including appropriate costings in applications of the funding bid. Building trust and relationship with those communities who do not engage with research should be your priority. Thank you.
That was beautiful, Sandra. Thank you so much for really setting the stage as to why it's so important to involve diverse peoples and communities in research, and that we can't expect communities and peoples to come to the research, that we have to go into those communities. And thank you also for sharing some solutions and first steps, that kind of stepping into being able to do this work as well. And now we are going to turn it over to Alma. We look forward to learning more about you and your work.
I just introduced myself here and greeted all of you in my Crow-Indian language. How are you? Today is a good day. It's good to see you. I'm Alma McCormick. I'm a member of the Crow Indian Nation here in Montana. I am the Executive Director of Messengers for Health. And I do the work I do from the passion in my heart of losing a little twin daughter to cancer. It was back when, the chemotherapy was still experimental, and she was diagnosed with a rare childhood cancer. She lived almost another year. Through that time, I developed my strong faith and relationship with God. I believed that she could be healed, but even though she passed on, it filled my heart with so much compassion, made me a better person, made me appreciate every day of life that we live here on this earth. As Crow people, we believe that every day is a good day. You never have a bad day until you lose a loved one. When someone passes away, that's the only time you can express that you've had a bad day. And so we are very thankful and we value life. And I want to share with you, and I just so thankful, Sandra, that was just, you just laid the groundwork there, and just such a beautiful opening for sharing what you have shared. It's just so easy for me just to come in as I shared this passion. I believe that divinely the door was just opened up for me to begin to do some work in the area of cancer awareness and prevention amongst the Crow women. Cervical cancer rates were very high because our women were not aware of what they could do to help themselves by just going in and having early screening. And so I was very blessed to meet a researcher. And I'm going to express her name, Suzanne Held from Montana State University, Bozeman. I met her and we developed a relationship before we did any work. That's the key. It is about relationships. I met her, began to just know her as a person. And then a few years down the road, she was eligible to apply for a research grant to address cervical cancer awareness and prevention amongst Native American women. And she did not just take steps and begin completing the proposal. She asked me. She came and sat at the table. And as was already shared, go to where the people are at. Develop a relationship with them. Our people, Indigenous people, and all the people, ethnic groups who face the greatest health disparities have been afflicted by historical trauma, as we call it. That is the reason why we don't want to trust. We're careful. It's almost like there's a guard, that we guard our hearts. But through respectful and mutual research, community-based participatory research, we can establish trust and build those relationships. This researcher that I work with, her heart is still vested in it. I still work with her today, and we began research in 2001. We were able to work together respectfully and mutually. She came and began to understand that we have a culture, she has a culture. It's mutual. You come to that mutual understanding and develop relationships. And for me, as a community partner, my people knew what I went through. They knew I lost a little girl to cancer, a little baby girl. She wasn't even 2 years old yet. Devastating trial. How did I cope with it? Because right now, the reality is there's a prevalence of substance use all over the nation, not just in my community. When people go through these times of devastation in their life, they turn to substance use to cope. How did I cope? My people know me. They know that this did not bring me down. And so they trusted me foremost. So if I'm bringing some people that are from the outside of our community, the trust that they have in me allowed them to let their guards down and accept and welcome this person who is here to walk with us, to work together side by side, true partnership. We are one of the very few, probably the only one I could say right now in the state of Montana. There's 7 Indian tribes. We're the only tribe that has taken that step of faith to welcome someone who is a research expertise, who's honored us as being expertise. The community, the Crow people, as me, as the partner and our board, we take the lead. She doesn't come with an agenda saying, well, this is how you need to do it. I'm a researcher. I have a PhD. I know the statistics. I know you people are, facing health disparities and live 18 to 20 years younger. You die at a younger age as compared to white people. No, she never come in with an agenda. She listened to us. She had us take the lead. That's what CBPR is, working together, honoring that each party has expertise. Our cultural ways, we've built it. Our Crow language, we speak our language, our native tongue, and we have resources and strengths in our community that we can utilize along with research methods. And when we work together respectfully and mutually, we will see great results. We did some significant cancer breakthrough in awareness and prevention amongst the Crow women. Crow women began going in. And then we recently just completed an intervention of improving self-care management when someone has any chronic illness. And that was, again, the same researcher. She did not come in with the idea. Our people came up with the idea. There's a high prevalence of diabetes. People struggle taking care of themselves. And so we want to use our cultural strengths along with research and work together. And it showed some significant results. We actually have just been working on what we call an indigenous evaluation method and perspective when we evaluate research, because it's all been Western approach research coming from a Western perspective. It has to shift. When we're doing research with any ethnic group, you need to honor their perspectives. And the research that we did with this last intervention, chronic illness, it showed significant results. Qualitatively, when I interviewed participants after they took part in it, one participant said, this program brought me out of my depression. Even in the midst of the research, we made it so comfortable and informal that people didn't feel like they were just being observed, to the point where one person said, this is research, but it doesn't feel like research. And I think that's the way our participants should feel, that they should not feel like when they take part in this research intervention as a participant, that they kind of have to follow these strict protocols to where they're kind of observed and they have to just watch themselves. I think it can be done in a manner where that this person feels, participants can feel like, yeah, this is research, but it don't feel like research. I feel comfortable. I feel like I can be myself, and that every research project should provide benefit to the community that you are working with. In this last research intervention, I was able to serve as the co-principal investigator. So we're talking equally, honoring, allowing community members to take the lead. I've been a co-author of many publications, and we have students working with us, Native American students going into the medical field. They get their hands-on research methods and the experience, but more importantly, that rapport. How do you work with an individual and to make them feel that you sincerely care, that you are there? When a person feels that someone cares about them, any human being, I don't care who it is, then they will let their guard down and receive what you have to share with them and apply it to their lives. And so we've been able to do so much. I'm just blessed. We've been around for 23 years now. I am still working with the same research partner. Now we are going on to address mental and emotional wellness, healing that goes back to the historical trauma. Our people need to heal. It's time for them to forgive. Forgiveness is the key to begin your path and journey of healing, so that our people can be well holistically. That's what we believe. Spirituality is our foundation as Crow people. And we want to be healthy and well in all areas, mentally, emotionally, spiritually, physically. And so I'm excited, as you might tell, and I'm so blessed to be a part of this, and I will stop there. Thank you for allowing me to share.
Thank you so much, Alma, for sharing your story, your experiences with us with so much vulnerability, energy, and honesty, and for sharing the relationships that you've formed in research that have lasted so long. I think that's incredible. And all of the work that you have done for your people. I'm so grateful to have you here today. And now we will turn it over to Cheryl and Hem. We look forward to hearing about you and your research together.
Kia ora, everyone. Thank you so much, Joe. Yeah, it is my pleasure to introduce Cheryl Davies. We both are joining from New Zealand. Kia ora, Cheryl.
Kia ora koutou katoa. Ka nui te mihi ki a koutou I tēnei wā. Ko Cheryl Davies ahau no Ngāti Raukawa, Ngāti Wihiwihi Oku Iwi. So my tribes are Ngāti Raukawa and Ngāti Wihiwihi. Yeah, kia ora. It's our pleasure to be here today, and I'd just like to acknowledge both Sandra and Alma for your presentations. It sounds so similar to our experiences here with Māori. Kia ora.
Kia ora, Cheryl. I think so. I'm a pain researcher and a physiotherapist. So we're going to share our journey of working with Cheryl for the last 7 years. Chronic pain in New Zealand affects 1 in 5 people. However, the burden is quite disproportionate for the indigenous population in New Zealand, Maori. As you can see here, Maori are 1.4 times at risk of reporting more chronic pain, and also people with disability have a higher risk, and that risk also increases with increasing age. And I think that's where this whole journey started. So, we know there was a higher burden of chronic pain in New Zealand, but then there was not much research to understand why is it for Māori, and I think that's where I went and met Cheryl. Cheryl, do you wanna talk about that one?
Yeah, kia ora. So whakawhanaungatanga really for Māori means building strong relationships. I manage one of the services, Tukotahi Māori Asthma Trust, and we're part of a large, what we call a whānau ora collective. So that's a collective of 8 Māori health, social service, education, justice providers, and we've been around now for just over 40 years. So we've been delivering a number of health and social services to our communities over a number of years. So it was really lovely to have him come out into the community. Just as Alma said, him came out to us to meet with us and to talk about this project that we're working on.
Kia ora, Cheryl. And whānau means family and significant others, and ora means well-being. So the way the whānau ora way of working is they not only focus on the individual, but their family and their significant others as a collective. So I think in one of the first sort of the meetings, we call it hui. And we spoke with our whānau. So I'm going to call our participants as whānau, so they become part of our family now. So for Māori wahine, for Māori women, I think the pain was, so they had a lot of multiple responsibilities within their family and community, and therefore pain was quite, became quite down in the list, and therefore expressing pain and also seeking help was a bit of a challenge. For Māori men, Māori tāne, pain was perceived as a sign of weakness, and therefore again, help seeking and expressing pain was a bit of a challenge. And I think it was the first time many of the whānau have said that they have been asked about their pain experiences, wasn't it, Cheryl?
Yes, so our first session was very emotional because many of our whānau had never had the opportunity to speak openly about the chronic pain they had been dealing with over a number of years, mostly because they didn't want to worry their families. Yeah, so that was a very emotional first session that we held.
And most of the whānau have said like it was the first time we spoke about it, and listening and supporting each other was quite therapeutic for themselves and for others. And then as a sort of a next step, we spoke with some of the community health workers, or kaya whina, who often support Māori whānau to appointments to their GPs or to the hospital specialists. What we came out what we found out was they were pretty much given pain medications that predominantly included opioids, and whānau were taking those medications quite diligently and developed side effects as a result of it. And it came to a point where they stopped going to their GP because they know what they're going to get. And what they also said was they were not explained about their chronic pain and how is it different from acute pain. And they were not even acknowledged about the use of traditional Māori traditional treatment like rongoa. So those conversations never sort of were fostered by the clinicians, and they were not also receiving referrals to pain services or tertiary pain services who offer those non-pharmacological treatments, which has the best evidence for. So that was quite heart-wrenching at that time for us to know in terms of the number of barriers the whānau were experiencing in the community. And then this is a bit of a summary of a couple of studies that was done in New Zealand. They have audited the sort of the profiles of patients who come and see a tertiary service. That's where I work. And I can vouch for this data because we don't see a lot of Māori or Pacifica patients in our service. And by the time they come to us, they present with very severe symptoms. So you all might have seen this picture on the right-hand side, like the equality approach, the equity approach. But what we want is more a justice-based approach. But as you can see from this research, like whatever we've been done, it's not working for Māori in terms of managing pain. And in a way, it actually increases or perpetuates the inequities that's already existing. So what we thought was perhaps we go back and talk to the experts. By experts, we mean we went back to the community again and we asked them what are their aspirations for pain management. And we thought an online sort of resource might be better. Again, this was all pre-COVID. So this is what they said the second time around in terms of when we asked them what their wish list could be. There's a lot of things here, but I really want you to focus on in the middle part of the picture, which says kanohi kite kanohi means face-to-face. They were very clear that they wanted something in person. Even though an online might work for some people, but they preferred an in-person option. But it was great to see they were already doing a lot of natural sort of treatments, like miri, which is a form of a traditional Māori massage, and then being connected to the nature. The Nahiri is more the forest, Moana is the water, and then also being connected with other whānau, other people with lived experiences, similar experience of pain was quite therapeutic. And we also gave them some creative materials in the hui, and this was one of the whānau members' creation. So they shared that these different beads sort of represent different whānau with different pain conditions, but they are all here learning and sharing and supporting each other in a safe space, which is a resemblance of a marae or a community house. And they were very clear that safe space was not a hospital, and that was more in a community, wasn't it, Cheryl?
Yeah, yeah. it was an interesting exercise. I wasn't quite sure how it would go when we first looked at doing this, but I think in hindsight it was a safe way for our whānau to show what was happening for them in community spaces, but also within their own whānau homes.
And then, so we had that meeting, and then we went back, and then we sort of collated some of the themes, and then we went back to the whānau again, and we asked them, we sort of fed them back, and this time they were very sort of clear in terms of what they wanted. So they wanted a program that was run in the community, like a group pain management program, led by a community provider like Cheryl. And then they also said, why don't we ask the pain specialist to come to run a clinic from the marae, from the community, as opposed to us coming to the hospital, because hospital was not a safe place. And that time it was an interesting meeting, wasn't it, Cheryl?
Yeah, we were a bit worried because we didn't have any funding at that time, but I think that's the importance of having a ground up approach and always knowing that what the community are wanting, instead of setting something up that we thought would be helpful, like an online service. And really what they were telling us was, you've done enough talking, now it's time for some action. And that was a good reminder as well.
Yeah, and luckily we got the funding, and then we were able to implement what Fana have said that they wanted. So we had a monthly pain clinic run by a pain specialist in the community. And then we also had some of the Maori community nurses and community health workers to come and see the tertiary service in terms of how the referrals work and what sort of services we offer. And then we also ran a community program led by Cheryl, and I co-facilitated it. So in the interest of time, we will share some few sort of highlights from the program, which we ran a couple of years ago. So we really want that to be focused on a strengths-based approach, and not necessarily on the individual, but on the whānau as a collective. And then we wanted to build on what whānau have already known. So one of the things we did at the beginning and at the end of the group was Mori Stone. So Mori means life force. So Cheryl, do you want to share about Mori Stone?
So really, the Maori stone that we used was a very special stone for Māori, and that was the pounamu, or the green stone, and it was very similar to this. And so we used that as an evaluation tool, really, and as a way of understanding how our whānau were feeling when they came to the group each week. So we would use the Maori stone at the beginning, and that would give an opportunity for our whānau to talk about their week and to talk about how things had been with their chronic pain. And then we used it at the end of the session to understand whether these sessions that we were teaching were actually, what value were they to our whānau, how had they found them useful. So it was a really, it was a good way to evaluate that didn't really feel like that we were evaluating. It was a safe way of doing that.
Yeah. And we also had been gifted a tohu, or a symbol. So this is the called nata. Nata means snail. It's used in Maori traditional treatment for treating some respiratory illnesses. So the way we used it for our program was the pain can make the person and their whānau to go within their shell. But the idea of this program is to help them to come out of their shell and still live well with pain. And this is one of the Maori health models. It's a 4-pillar model. As you can see, health and well-being is seen as a sort of a balance of all of these aspects. And that is something that the mainstream don't do a really good job on this. And the way we worked around was we worked with another artist, and then these images became sort of the logos for our 6 sessions. As the program or the session went, it helped the whānau to come out of their shell, even though the pain remains. So they used it in the program to ask whānau some of the things that actually go within their shell due to their pain. And then we also asked them to write some of the things that help them to come out of their shell. And here's an example here. Whānau said, whakama means the stigma of being in pain, and also the disconnect that pain brings, the historical racism, all of those things as sort of things that make them to go within their shell. And then they wrote a few things around their physical aspects, their emotional aspects, their natural aspects. Again, we did that exercise in the first session and in the last session. So that was our sort of the pre-post sort of questionnaire. It was great to see like there were a lot of things were written in the shell part in the first session. And it was good to see that whānau wrote many things that were discussed in the program in the snail part towards the end of the session. And we also had some animations, which whānau really enjoyed. And I think this was the best of the 6 that was run by a Māori traditional practitioner, the Rongoa, wasn't it, Cheryl?
Yes, so what we wanted to do was to encourage our whānau to talk about Māori medicine and to not feel whakamā, or to not feel worried about sharing the fact that they were taking Māori medicine, because many of our whānau said they didn't feel comfortable sharing that information, or in fact they had stopped using it completely over a number of years. So yeah, that was a good learning as well.
Yeah. And they were saying how Rongoa can be complementary to the mainstream and not as an alternative. And we also reinforced the messages from the program, and we created a dedicated booklet for whānau to have a look at again. And then we also created an online version of the program so that some of those community health workers, while they're working in the community, they could reinforce some of the key messages, or could do a sort of brief pain education in the community. And I think our final thoughts exactly aligns with what Alma and Sandra was saying. I think the whakawhanaungatunga, the process of establishing and managing trust with the community is super important. And yeah, like the co-design, the participatory approaches of working with community and the power of metaphors, wasn't it, Cheryl?
Yes. So these are the key elements, or the key values that we as a community provider ensure happens when we bring other researchers out to work with our communities. So it was really good to have these key values in place when we started developing our program with them. Kia ora.
Yeah. And we also asked our whānau like what they thought about the program. So we made a short video sharing their experiences, but it was great to see that whānau said they started to look at things in a different light, and they all wanted to sort of prioritize their self-care as well, and then also use more traditional treatments. So we were lucky
So
to
him,
continue. Yeah, sorry.
I don't want to cut you off, but I want to make sure that there's time for discussion. And
Yeah.
we've already gone a little bit over, so I don't know if you can wrap it up in about a minute.
Sure. Yeah. Thank you, Joe. So I'll just finish off with this slide here. So we got some funding to continue on this work. So Cheryl and I are working on to develop a support intervention to help some of the whānau to come off their opioids for their chronic pain recently. So yeah, that's our last slide. Thank you very much.
Perfect. And maybe Hem, it would be great if you could share that video, the link in the chat. I think people would really enjoy seeing the video. And
Sure.
thank you both, Cheryl and Hem, for sharing both your relationship and the work that you've done together. I think it's a really good example of how this is put into practice, because it can be very abstract for people and not really understand the process and the steps along the way, and also like how how long things might take. Like you said, your relationship started 7 years ago, and I know Alma's been working with her research partner now for over 20 years, that the really good stuff comes from these long-lasting relationships and getting to know each other as people. And there are so many themes that have come through. Sandra and Alma, if you could rejoin us on your videos, we'll get into some discussion now too. We have about 15 minutes left before this session is over. A very prevalent theme through all of this is the importance of going into communities to establish these relationships rather than making the community come to the research, and how it was really striking, I think, to hear it presented as it being unsafe. And I don't think a lot of people think of it in that way, that these environments like the hospital or health systems or academic systems and institutions could actually be unsafe for some of these communities to come into, and that importance of going into the communities to establish those relationships and build that trust and that familiarity and all of that. I've noticed that was coming through a lot in the chat, so I just wanted to bring that up. We have one question directed towards you, Sandra. I know that you've already seen it because you've selected that you would like to answer, but I'm going to read it just so everyone can hear it. And this is from the perspective of the person asking the question. I'm a person of color as well and have benefited from a great education and career. I am here as a caregiver to a minor child with a rare diagnosis. I don't like the idea of being included as a patient partner just because I am non-white. I feel I should be included because of the valuable insights and experience I have in a very challenging, long-standing role as a caregiver. How do I know if I'm being included for what I have to offer rather than being a token? Thank you in advance for your response.
I have been exactly in that position when I started off my journey as a patient partner in research. And always, whenever there's an opportunity, there would be a diversity clause. We would like people from Asian ethnic backgrounds to apply, and I would apply and I would get the role. And sometimes I would feel it was very tokenistic because they wanted to tick box. And then over time, I learned how to question, how to make myself inclusive, to show them that I have other skills and knowledge and expertise, and challenging them. And if you feel like you're seen as somebody just for tokenistic value, I always challenge them. I always ask them for feedback. I always say, okay, I said this in my last meeting. Did you take what I said into account? What have you done with it? So it's something like, you said, we done. So nowadays, when I am part of a research team, we always have got something called the feedback session after our meetings. So we provide feedback as to how the meeting was run. Was I made inclusive? But we must understand that there is a reason why they want people from the ethnic minority groups to contribute their expertise in that particular area of illness. So it's not just one person. You could have the rest of them could be white and just one person from the ethnic minority. We have to stand it. We have to make that work. And over time, and I realized that the way I work with people have made them realize how important to have inclusivity in the study.
Thank you so much, Sandra. Beautifully said. I wonder if, Alma, do you have anything you would like to add to that about tokenism in general, or how do you know when you're valued as a patient partner?
Okay, and I think I kind of touched on that a little bit when I was presenting, but we've just felt honored, okay? Just felt that our insight, our input, our expertise for me as that partner, and most even importantly, our advisory board, our board, they are valued, and I believe we felt that. And for me, I grew into a leadership role. I did not think of myself as a leader from the beginning, and it was something that, even in my community, as a woman, and like I mentioned, people know you and they know your character, but it wasn't like, I became this leader. I was already a leader. I kind of grew into this position. And in this partnership, we have both learned and grown together. In fact, my research partner has mentioned, I have become a better person because of you. And I feel the same way about her. And then the impact that she has upon our people, the Crow people. And they just feel, she's vested. Her heart is in it. We feel that love. When she comes into the room, when we have our monthly meetings, she drives 3 hours to get to the reservation. From the university, she will drive 3 hours, and when she comes in, she's hugging our people. They hug her. There's a relationship, a rapport that she's developed, not only with me, but with our board and the community members. So
that's beautiful, Alma. And I love how you brought in love. That was a common theme that came through in the first session too, that bringing love to this, I think, is so important too. And that mutual respect and that shared learning, where you're learning from her, but she's also learning from you and your community too. And that shared learning or co-learning, I think, is such an important aspect of this. And all of that knowledge and skills and expertise and experience that patient partners, or however we want to define ourselves, bring to the table beyond, just the labels that are assigned to us. Cheryl, I wonder if you have anything to add to that conversation, and if you've felt tokenistic at times and how it might be different with Hen.
Yes, very much so. So we've been working in research for the past 25 years. When we first started, it was a very tokenistic process, and there was always a feeling of I always felt a little bit of concern about bringing researchers out into the community, and just we weren't set up then, and we didn't have our own processes in place. So things have changed a lot over time. We like to be involved at all stages of the research now. We like to be involved in how researchers go out into our communities, and what values they go out and work with our whānau. It's just, I think it's about trust. It's about aroha or love. That's absolutely a huge part of how we work as well. The whānau that work on our study, they've been with us for 7 years, and that to me is a testament that they trust him, they trust the research that we're doing, and we're working in the right way with them. Yeah. Kia ora.
I'm going to keep you on the spot just because something that you said struck me about being nervous to bring researchers into the community. And I wonder if you would like to speak to how you navigate that, the trauma and the distrust that people might have, and bringing people in from outside of the community has to be difficult at times. And there has to be challenges that have to be navigated through that. And I wonder if you could speak to that.
I think when we first started working in research, there was a huge distrust amongst Māori people with research, and a lot of that was due to the fact that nobody ever came back to them and told them the results of the research that was happening. So when we first went out, they always felt like research was done to them and not with them. So a big part of our journey over the years has been going out into our communities, sitting down and asking our whānau, how would you like us to work with you? And we've developed a framework based around the feedback that has come back from our whānau. And a lot of the feedback that they've given us is absolutely about feeling trusted, feeling valued, being shown, aroha or love, and feeling, like we say we give koha, but what we're doing is acknowledging them for their time and often for the knowledge and the experiences that they share with us. So those have always been the important values that we ensure happen with any research studies that we work alongside our communities now.
Thank you so much. Alma, do you have anything you'd like to add to my poorly worded question, but Cheryl nailed it, the answer.
It was, for us, when we first started, and like I said, my research partner, the way she came in, the trust didn't just immediately take place. It took a little time, and I am so thankful that American Cancer Society funded us for like 2 rounds of 5 years of funding, because it takes time to build trust. And it wasn't like anybody said anything, but like the best illustration I can use is like, we have our guards up, and this person is coming because of some experience too from people that have come in, done, conducted some surveys, and then, saying they're going to do this and that, and you took part in it and nothing came about. And so it was those kind of things, and poor research that was done with other Native American tribes in the United States. Even though it wasn't done to our tribe in particular, it was done to another tribe. So research is almost like people shied away from that word. But by being able to do it in the right, respectful manner, we've kind of allowed people, like, it's not so bad. We've welcomed this individual, and she's with us for the long haul.
Right.
She didn't get successful. I'm telling you, you can go to our website and, publications we do have, we're nationally known. We presented, awards and everything for what was done in this little project.
Right.
But she has not left our side. She helped us transition into a nonprofit, 501c3. And she's gone above and beyond, volunteering her time and her effort to help us establish us as a Native nonprofit. And we're probably the only one in the state of Montana that's addressing health as a nonprofit. Very unique to be a research project and then transition into a nonprofit, allowing us to kind of have the liberty to address other issues. And
Right.
so that's what can happen when
tangible,
the heart is right.
Mm-hmm. Right. Very tangible benefits for the community in collaborating in this work, which I think is so important. And like you said, not just having research done to you, but for you and with you as well, and that those benefits do come back to the community. There's a lot of it harkens back to your initial presentation, Sandra, about that investment of time and resources into building these relationships. And I wonder if you'd like to speak a little bit more to that and overcoming these challenges of bringing researchers into the community, kind of flipping the script on that.
I have been also involved in reviewing research funding applications from a patient and public involvement perspective. So we bring in our expertise to see whether the research questions are the right questions to ask. And then I always will look for the costings that's done in the funding to see whether they've allocated any fundings to patient and public involvement. When I see a study is for 5 years, and I looked at the percentage of funding set aside for patient and public involvement, or patient engagement, as you call it, it would be insignificant amount. And that in itself, I would say, no, go back and revise your funding costing. That is one way of ensuring that, people listen to what you're saying. And how could you have good patient and public involvement in research if you're not allocating resources? You're not remunerating the participants or the patient engaging the patients in your work, working with them, co-producing the research from the start, from inception to dissemination, that I would say throughout the research cycle. So that is one way of actually challenging them. If you want to do it, you have to make sure you have the resources to do it.
I love that. And that's a call to action, not just a statement. It's a call to action. So I'm being a terrible host, and I got so engaged in the conversation, I've lost track of time, but I would still like to give everyone 30 seconds to just share their biggest takeaways. And Hem, I'll start with you.
Okay, 30 seconds. People with lived experience, you live with a condition 7 days a week, 365 days a year. So for me, you guys are the experts, and any research without people with lived experience or experts of lived experience, I don't see that as a meaningful research.
Cheryl, I'll go to you next.
I think I'll just reinforce the importance of working with the communities and the importance of always having their input throughout your research studies. Kia ora.
Sandra, I'll go to you.
I want to say that researchers do not come with they were not, when in the education level, they were not taught about patient and public involvement or patient engagement. So give them, that break and work with them lovingly, like what Alma would say, rather than just pointing to them, you're not doing it right, but, express your concerns and help them to develop that skills as well.
Wonderful. And Alma.
It comes back to the heart again. When your passion is in it, as in that partnership, when both partners have their hearts vested and they have that passion, they can work together respectfully, mutually, with humility, and some good results can come out of that to benefit the people.
Beautiful, beautiful, all of you. Thank you so much, Sandra, Alma, Cheryl, and Hem. This session's been invaluable. Thank you so much for sharing your stories, yourselves, with so much vulnerability, honesty, and with solutions and hope too. Thank you all to the audience too. There's been great discussions in the chat, and we are going to take a break now for about 29 minutes. I didn't go too much over. And we will be back on the hour for the third session, Amplifying Outputs and Impact of Research. Just so everyone knows, the hosts and moderators kind of hang out in that 30 minutes, so you might hear us talking, and that's okay. We know you can hear us. And we will see everybody back here in 30 minutes. And again, just a huge thank you to our panel today. This was incredible, and I am so honored and grateful to have been able to moderate this session.
Thank you.